Hi, how are you all doing? My name is Clark Kensinger. I'm the Chief Medical Officer of LifeLink Foundation, which is one of the organ procurement organizations in the United States. They service Georgia, Florida, and Puerto Rico in regards to managing donors. I'm also the medical director of our donor care unit at Piedmont, and I'm a transplant surgeon. I am the surgical director of our kidney pancreas program at Piedmont Transplant Institute, and I do liver transplants as well. And so we're top 10 in volume in the country as a transplant program. So it's an honor to be able to work both with recipients and with donors, and having that perspective of what is safe to use for transplant really helps inform my approach to critical care and managing donors. And so with that, it's an honor to be able to present my thoughts on donor care management. And it's a privilege to be able to present our work with you all. So today I'm going to be talking about innovation in donor management and how we can apply high quality critical care to saving more lives. And so the outline of this talk will be going through the model of donor care units, then we'll move to organ-specific resuscitation, and then some outcomes. And so United States, in the last 5 years, the government has really encouraged the development of specific specialized donor care units to provide higher quality of care, consistent care, standardized care to both the donor and the donor family. And this was in the National Academy of Science and Engineering and Medicine report, really encouraging organ procurement organizations to partner with local transplant centers to form these donor care units. And so the traditional model that OPOs did in the past to help manage and allocate organs for transplant is that they would send their team to different hospitals, donor hospitals throughout the area that they serve. And so this is just representing that LifeLink would send their team stationed in Atlanta, the capital of Georgia, to different small communities throughout Georgia to manage the donor independently. And so we flipped that model on its head. And so we move donors to a ICU that I run at our hospital that we partner with LifeLink to really accomplish high level of critical care management. So we're moving about 70 to 80% of the brain dead donors in Georgia to our ICU. And the mission of our donor care unit is to provide specialized critical care, and that allows us to improve quality, improve transplant rates, and save more lives of those patients who are waiting on the waiting list at different transplant centers to allow more organs available for safe transplantation. This is a view of one of the rooms. We have 6 ICU beds that are just for donor management and donor care. This is the operating room. There's 2 operating rooms. Again, these are only for procurements. There's no other scheduled cases. These are only LifeLink's operating rooms for the purpose of procuring organs for transplantation. And we have family lounges. We have a concierge service to interface with donor families to ensure that if they do come to continue to be at the bedside with their loved one, that they have a comfortable place to sit, they get food vouchers, etc. And so the advantages of the donor care unit, as I mentioned before, in the past, LifeLink would send a transplant coordinator to interface with that donor and manage that donor independently. And so they were a little bit on an island. But at the donor care unit, it's a huge team that's taking care of this patient. It's an ICU level of a care model. We have 20 ICU nurses that just think about donor care management. They know the protocols. I have 4 advanced practitioners that help me provide high level of care. I'm the only intensivist, so I really lean on a high quality nursing staff and nurse practitioner team to be able to accomplish really elevated management of these patients. We leverage our respiratory therapy team to really help with our lung protocols as well. And of course, the LifeLink transplant coordinator is part of that. So it's a huge team effort, but it's also really important that Piedmont, as a large hospital system, LifeLink and the donor care unit can leverage the different service lines to get a lot of support and a lot of management done in a short period of time. If that's frequent imaging, if that's cath lab, um, it's really, leveraging all the specialized service lines that Piedmont has to offer. We can, again, do a lot of donor management in a short period of time. And so there's been a paradigm shift for the culture of how we manage donors within LifeLink, and I really believe that our donor care unit has driven that in our philosophy. And the philosophy is there's no rush to get to the operating room for procurement or start allocating organs. The longer that we spend in a resuscitation phase before we think about getting the diagnostic imaging that's required for allocation, such as CT scans or caths, we need to really focus on resuscitating these patients, resuscitating their organs to make them higher quality, safer to use for transplant, and get these and allow more organs available for transplant. And so, with our success, seeing that the longer that we lengthen out donor management, the more organs we get transplanted. You can see that our length of stay since we opened 5 years ago, we're celebrating our five-year anniversary this year. Our length of stay has doubled. We're now managing patients for 80 plus hours. And the image on the right is looking at LifeLink's cases of a DBD or brain dead patient versus a donor that's dying from cardiac death. You can appreciate the length of time that once we opened in 2021, that you can see the increase of case length, and that is all due to us believing that the more critical care that is being provided, the more organs that are going to be safely transplanted. And so we're very protocolized. We update our protocols every single year, and we're trying to always process improve. And these protocols are based now, there's some consensus guidelines. The one on the left was published in 2015. The Canadian guidelines was published in 2020. Now this is, we have our foundation, and it's just kind of figuring out the best way to manage patients and be able to resuscitate these organs. And so I'll break down our approach to hemodynamic optimization, cardiac resuscitation, pulmonary resuscitation, and we'll start with hemodynamic optimization. And I think it's really important to step back and think about what's the best way that we can provide care to these patients. And so there's something called donor management goals that OPOs try to track from a quality perspective, to track their transplant coordinators, and they're very static measurements of endpoints of resuscitation or quality care. And I think that we can provide higher level of care, and so we've moved beyond these static points of quality and care to really thinking about the patient physiology as you would in any patient in the ICU. And we don't resuscitate to a number when we're taking care of someone with sepsis. We are thinking about the physiology and the complete holistic approach to critical care. And so that's what we are applying when we're managing these patients in our unit, is really moving and thinking as if this is a true critical care patient, and we're really focused on organ-specific resuscitation. And we have a lot of work to do. After brain death, and during the brain death event, there's a new physiologic insult to multiple organs from that brain death event. There's a sympathetic storm that occurs, and that cytokine release and increased inflammatory markers all lead to downstream effects to the organs. So you can get a cardiomyopathy from the heart, you can get increasing lung edema, and hemodynamic instability following this brain death event. And so, we've cared for more than 1,000 brain dead donors in our donor care unit over the last 5 years. And so there is a pattern recognition that develops that you get to see that post brain death. These patients following the cytokine storm have a vasoplegic shock. It's the same phenotype of shock as a distributive shock. And so we have to continue to treat through that and allow the vasoplegic state to resolve. And it usually resolves within 24 to 36 hours after the brain death or herniation event. And so it's really important that these patients continue to have ongoing intravascular volume resuscitation. Even if they are 20 liters positive from their trauma stay, these patients are undergoing a new physiologic distributive shock event that we need to, and our team really focuses on ensuring that they remain intravascularly resuscitated. And so our team really focuses on dynamic measurements of fluid responsiveness. If we give volume, does that improve preload? Does that improve stroke volume? Does that improve cardiac output? Can I have recruitable cardiac output with fluid resuscitation? That is what our team is constantly discussing when we initiate our resuscitation shortly after the patients are declared brain dead and get moved to our unit. And so our team focuses on dynamic measurements of fluid responsiveness. So how can we take multiple data points of stroke volume variation, pulse pressure variation, what happens to the MAP, the cardiac index, the pulse pressure variation to a passive leg raise. We couple that with echocardiograms to evaluate IVC filling and distension. And we also use tidal volume challenges to evaluate and watch what increasing intrathoracic pressure does to preload and stroke volume and subsequently pulse pressure variation. So our team has a very protocolized approach to how we evaluate these patients. And it's been amazing to watch the nursing team and the nurse practitioner team over the last 5 years start really becoming excellent clinicians to be able to think through where a patient is in the resuscitation process. And so they're really bringing together multiple data points. Like I mentioned, what happens with the passive leg raise? What happens to the pulse pressure variation? What happens with the fluid administration of 500 cc's to the bedside flow track monitor and stroke volume variation changes? So we're utilizing a lot of dynamic points to evaluate where that patient is on the resuscitation curve and trying to eloquently resuscitate them and not have them volume overloaded, but ensure that they're intravascularly replete and they are optimized on the Frank-Starling curve, and we're not and our recruitable cardiac output is achieved. And so there was a paper that was published by the Mid-America group. Gary Markland's a pulmonologist, one of my mentors, and they published a stroke volume-based protocol resuscitation and resuscitating brain dead donors. And what they showed was that there was a trend in more organs transplanted per donor when you have a very structured, protocolized approach to resuscitation. And just as an aside, quickly on vasopressor options, we use norepinephrine as our first-line agent during these hemodynamic instability moments when the patients are initially arriving to our unit. Something that we've been using more and more frequently is angiotensin II as well. That's what I want to mention. We use it in patients who have acute kidney injury to help prevent the exposure of catecholamines and any type of renal blood flow restriction that may result with alpha agonists and vasoconstriction. And so angiotensin II has been shown in distributive shock to improve renal recovery in the Athos 2 trial with in a subgroup analysis. They had improved renal recovery in patients with distributive shock treated with angiotensin II. So our team reaches for angiotensin II when we have a donor who has developing stage 2 AKI or a doubling of their creatinine with ongoing catecholamine requirements. And so again, we're trying to create a reproducible standardized care delivery model that the nurses can replicate time and time again to really eloquently resuscitate these patients. The next thing we'll talk about is hormonal resuscitation. These patients all are obviously brain dead and had a traumatic event, and they are losing pituitary function, and so vasopressin is a very important piece of our protocols. Every single one of these patients, and I'm not exaggerating, all has some degree of central diabetes insipidus, where they don't have any vasopressin that's released from the pituitary gland, and you subsequently have no upregulation of aquaporins in the collecting tubule of the kidney, and so you have a massive amounts of free water losses that patients can develop severe hypovolemia and hypernatremia very quickly. And so this goes back to the donor management goals that I mentioned earlier. One of the donor management goals is to preventing sodium increases and keeping your sodiums below 155. And when we first opened, the transplant coordinators were just providing D5W to treat a sodium, but what they really needed to be treating was their central diabetes insipidus. And so we're very, very focused on diagnosing diabetes insipidus quickly and treating these patients appropriately with drip vasopressin. It's dosed units per hour to allow a more therapeutic window that the nurses can really titrate and target a appropriate hourly output goal for urine output. We really avoid D5W, and we do enteric-free water. D5W is just going to hurt what our process is and our progress for lung resuscitation. So shifting to thoracic management, first cardiac resuscitation. When we have a challenging donor that is not behaving, meaning that they have ongoing vasopressor requirements beyond that vasoplegic shock that we mentioned earlier. Again, that vasoplegia usually closes and resolves within 24 to 36 hours. If we have suspicions that they have ongoing hemodynamic instability, we will always get a formal echocardiogram during the early phases of resuscitation. And it's important to be able to diagnose stress-induced cardiomyopathy versus a more global or regional cardiomyopathy, because we manage those patients differently. If it's a stress-induced cardiomyopathy or a Takotsubo's form, a phenotype of cardiac dysfunction, we want to avoid inotropes to allow an environment that will encourage cardiac recovery. However, if the patient doesn't have a diagnosis of a stress-induced cardiomyopathy, then we can use low-dose inotropes, and we use dobutamine as our first-line agent to help with forward flow if we're having issues with end organ perfusion. And so our protocol for cardiac resuscitation is largely just supportive care and time. It's focused on afterload reduction, appropriate volume optimization, electrolyte replacement, zero echocardiograms to ensure that we're managing this patient appropriately and we don't need to change any of our approach to our volume resuscitation or our vasopressors. We do place Swan-Ganz catheters occasionally if we do feel that we have elevated PA pressures that we need to have a closer eye during our diuresis of that patient. And time is the most important. We have no pressure to get these patients to the operating room. It's only a donor care unit. It's our ICU, and so we can spend days allowing this stress-induced cardiomyopathy to resolve. In 2023, I was part of an author group that published this trial in the New England Journal of Medicine looking at intravenous levothyroxine in unstable brain-dead donors. And so this was a landmark publication in donor management, because before this publication, the vast majority of organ procurement organizations in the United States were using T4 in cardiac resuscitation. And so what we did in this study was we randomized, this was the largest donor study that has been performed in the United States. We randomized 800 patients to either receive T4 or placebo, just normal saline. And this was a multi-center collaboration across 15 different organ procurement organizations across the United States. And what we showed was that T4 did not improve transplant rates of the heart compared to placebo with saline. There was no difference in graft survival post-transplant of the patients treated with levothyroxine or T4 versus saline. And there was no, and this is another really important finding, there was no difference in time of weaning vasopressors. This was a classic thing that transplant coordinators used to call me and be like, I'm starting T4, I'm on a bunch of pressors, and it worked to get the pressors off. That's not what led to getting the pressors off. It was volume resuscitation and time to allow that vasoplegia to resolve following the brain death event. And so again, our study did not show any improvement in getting vasopressors off compared to placebo. The other important piece of this was that levothyroxine did not improve cardiac function in patients who were coming in with some reduced ejection fraction. And so there was no difference across multiple subgroup analysis, as you can see in this table. There was no improvement at all in any outcome between patients treated with saline and those patients treated with T4. But there was increased adverse events. There was higher rates of severe hypertension and tachycardia. So we have stopped using T4. I think a lot of OPOs across the country have finally started adapting that protocol as well, since it's been several years since our publication in the New England Journal. Next, we'll transition to lung resuscitation. And one of the pieces of lung resuscitation is that we just extrapolate a lot of what has been shown to improve survival in severe ARDS to our lung resuscitation for donors. And so one of the most important pieces of that is prone positioning. And as you know, there was a landmark study in 2013 published in New England out of France showing that there was improved survival in patients who were prone with severe respiratory distress syndrome versus supine. And what we are leveraging here is this is a static image of a patient that we see is that they have a lot of consolidation in their bases. But when we prone them, we are improving our ventilation and perfusion matching of healthy lung. But most importantly, though, for our purposes, is that we are trying to achieve complete radiographic resolution of atelectasis or pneumonia. And so our resuscitation and our recruitments target the areas that are at the bases, but now they're anterior, which is our recruitment maneuvers improve reopening of those distal airways when the patients are prone. And so we prone these patients within the first 1 to 2 hours of hitting our doors on admission. We keep them prone for at least 24 hours. We often prone for 48 to 72 hours before we consider the allocation CT scans, and we perform prone bronchoscopies. We're doing bronchoscopies every 8 to 12 hours during the resuscitation phase. The other thing that we've started to do is really provide individualized care within protocolization. And so if donors have imaging modalities that once we get CT scans that we feel that we can improve quality, we pause allocation, repeat imaging after 24 to 48 hours, and we have improvement in our our right lower lung with more time. And so we really focus on trying to really have the perfect CT scan for allocation, and we do repeat imaging when we feel like we can improve that quality. Antibiotic management is extremely important. We are doing lung-targeted antibiotics, and it's a broad spectrum approach. We treat every single donor that is a potential lung donor with vancomycin, cefepime, and Flagyl. We use linezolid as well to prevent any vancomycin-induced acute kidney injury. And again, the approach here is radiographic resolution of pneumonia and not clinical stability. And so it is imperative that we treat all these patients with broad-spectrum antibiotics. And as we've evolved through the last 5 years, we've really focused on, again, precision care and individualized care. And so now when we are moving to allocation, we are really thinking about preventing overexpansion of our lungs. Because we've gotten so good at our lung resuscitation, there is times when we're in the operating room doing the procurement that we've actually overextended lungs. And so what we are trying to accomplish now is trying to tailor our care towards the end of management based on diaphragm flattening and expansion on rib expansion on chest x-rays to target our recruitment maneuvers that are performed every 3 hours during the resuscitation phase. Once we switch over to allocation phase, we are lengthening that recruitment frequency out based on, again, where we are on our compliance curve of the lungs to prevent overdistension. And this is a constant improvement. Over the years from 21 to 25, if you look on this table from left to right, you can see that our number of lungs per donor is increasing nicely as we refine our protocols and we're striving for excellence in quality. And where this is really highlighted is in our older donor population, where we are seeing success in getting older donors that even have smoking history successfully transplanted. You can see over the years our success is growing in older donors and allowing these patients time and really having intensive protocols to get these lungs safe for transplant. So kidney optimization is really a push and pull, as you know, between thoracic improvement in terms of volume and getting volume off, but doing so that we're not inducing acute kidney injury. And so our goal here in donor management is to get fluid mobilized to improve tissue, to decrease tissue edema, interstitial edema, and we use a LASIK metolazone spironolactone combination coupled with ongoing treatment of DI with vasopressin. Our goal, again, is mobilizing that interstitial fluid out. And so if you are not treating diabetes insipidus during your diuresis of these donors, then you're going to have just free water losses, and you're going to have a shift of intracellular fluid into the extracellular space. What we're trying to accomplish again is moving the extracellular fluid out. And so we are really focused on getting an isotonic diuresis. And so we do that through a nephron blocking approach with a loop diuretic, a thiazide, and a spironolactone or case-bearing diuretic if we need to, based on our electrolytes. It's important to always think about coupling vasopressin and ongoing diabetes insipidus management. When you're diuresing a patient in the cardiac ICU, they have physiologic background of vasopressin when you're diuresing these patients. And so we have to provide that to ensure that we're not having free water losses in order to achieve an isotonic diuresis. And so the most efficient way to remove fluid, as you all know, is through continuous renal replacement therapy, where you can set an hourly goal. And so our team is trying to be as smart as a CRT machine. And so we set a rate on our Lasix and vasopressin drip to achieve a urine output per hour goal. And so it's an ever-changing balance. And the nurses have to go in every hour to adjust the loop diuretic and the vasopressin to achieve that goal. But the philosophy is to prevent a massive amount of urine output in a short period of time. If you bolus 40 milligrams or 80 milligrams of Lasix, you potentially could cause a large volume output of urine that could lead to under resuscitation or under perfusion of the kidneys, and then exacerbate your acute kidney injury or prevent acute kidney injury from recovering. And so our approach is to focus on a slow and steady methodical diuresis where we're targeting a low urine output per hour, net negative urine output per hour, to ensure that our kidneys are happy, but at the same time achieving our goals of interstitial volume removal. And so we are providing precision care in this space. Again, this is a protocolized approach, but individualized care, where we think about where the patient is in regards to their intravascular volume, their weight, and how quickly we can get volume off. And so our team is evaluating dynamic measurements of fluid responsiveness to choose what hourly output goal we would want, if that's 50 cc's an hour or if that's 150 cc's per hour. And so we leverage pulse pressure variation, response to PEEP challenges during a recruitment maneuver to evaluate and be a smart, quote unquote, CRT machine, where we can safely remove fluid in a very methodical, slow way to get volume off. And as we refined our approach over the last several years, our urine output removals during the resuscitation phase has improved. And so we're getting patients 6 to 8 liters negative over 3 days. And we're doing that slow and methodically. Our sodiums are coming down, so we're treating DI appropriately, and our creatinines are coming down. Even when we get patients 10 liters plus negative with our diuresis protocol, we're not causing acute kidney injury. And our lung transplant rates have improved, but our non-use of kidneys have decreased, meaning that we are really focusing on good renal perfusion and preventing acute kidney injury, despite getting a massive amount of fluid off to really improve tissue, edema, interstitial fluid, and quality of these organs for transplant. There's publications around the benefits of continuous renal replacement therapy in donors. And so our protocol at the donor care unit is, if we're not hitting our diuresis goal, if that's 100 cc's net negative an hour or 150 net negative an hour, and we are not moving volume and we still have organ improvement to achieve, we quickly start CRT. And this publication showed that if you're not achieving your diuresis goals and you start CRT compared to a historic group that did not have CRT, you were able to achieve higher rates of organ transplants per donor with CRT initiation. And so again, if we're not achieving our urine output goal per hour and our volume status goal, then we quickly get to CRT. And through we've had more than 100 donors at this point that we've managed with CRRT, and we know that the longer we manage them on CRRT, the more fluid removal that we're able to accomplish in our thoracic organ transplants increases with the longer management phase of these patients. So quickly on liver optimization, livers is largely is placed largely on non-modifiable factors, BMI, alcohol history, hepatitis history, etc. But what we can do is ensure that the livers are not getting congested, so manage right heart issues, elevated pulmonary pressures, and manage volume status. Ensure that you're frequently testing liver function test and optimize serum levels, because there is some older data that I think is outdated at this point, but there may be some transplant surgeons who worry about hypernatremia in these livers and their recipients on reperfusion. And so those are the things to think about for a liver optimization. For the unstable donor, we oftentimes get these patients from our level 1 trauma center in Atlanta who are very unstable, as you can see with this chest x-ray, with horrible ARDS. And so our approach is a very aggressive critical care. We use inhaled prostaglandins to help reverse and treat hypoxic pulmonary vasoconstriction. We ensure we do our bronchoscopies, ensure there's no mucus plugging, and we again are guiding our resuscitation with flow track and bedside echocardiograms. If there's any pH imbalance or anything that we need to optimize with CRT, we can start that quickly, and we do leverage VA and VV ECMO if we think that we can improve quality of organs prior to going to the operating room in an expedited fashion. And so this is all, again, focusing on the resuscitation phase of the care of these donors. Okay, lengthen this out, provide organ-specific resuscitation, and your outcomes are going to improve. And so if you look at our care over time of donor care unit versus non-donor care unit transferred donors in Georgia, there's similar age and similar covariance that we look at with the kidney donor profile index represented by the KDPI. It's a composite score of 8 different variables like hypertension, age, diabetes, creatinine, that kind of captures the medical history of the donor. When we manage these patients at the donor care unit, we have improved lung utilization, we have improved heart utilization, and we have improved kidney utilization. Again, our elevated approach, our team effort, our collaboration, it really improves our ability to resuscitate these organs and get more organs transplanted. And so in 2025, we had a 3.94 organs transplanted per donor. That is almost one more organ per donor that we're able to resuscitate and successfully transplant when the donors move to our donor care unit and apply this elevated critical care approach when compared to the donors that don't move. And so, you can see in the blue graph there, compared to the U.S., which is about 3.4, that's the national average. Again, that's half more organ per donor. And if we're managing 200 brain dead donors a year, that's 100 more organs that are being able to be successfully transplanted. So it's a significant impact to the transplant patients waiting on the list throughout the entire eastern seaboard of the United States, based on our ability to get more organs safely resuscitated. And I'll finally close on this. I know I've gone over time, but we also are moving donors that are donating through the process of donation through cardiac death. We're moving these donors to Piedmont as well. They're being managed by the neurointensivist team, but also the donor care unit team gets mobilized to care for them. As a transplant surgeon, I'm not able to care for these patients, obviously, prior to their declaration, but the team is having standardized care, collaborative effort, and we are able to utilize the ORs within the donor care unit to provide a very respectful withdrawal environment where we can apply normothermic regional perfusion NRP on all of these donors. And the DCD transfers to Piedmont in 2025, we were able to achieve an organ transplanted per donor of 2.5, and that's compared to the national average that's usually less than 2. And so again, we're getting half more organ per donor, if you will, based on higher quality of critical care, of these patients who are awaiting donation through cardiac death. And so, my mission is to, just as a summary, is to have focused donor management that really improves the quality of organs available for transplant, improves transplant rates, and saves more lives. And then that also feeds to how patients do postoperatively. The better the organs, the less acute kidney injury, the less pneumonia that is in the lungs that are being procured for transplant. These patients do better postoperatively. So it's a full continuum of care, from donation, of donor management, to recipient outcomes. And so I really want to thank you all for the opportunity to present to you all, and hope everyone's well, and be safe. Take care.